I want to thank you for joining us for this week's discussion we're calling Mobilizing to Respond to COVID-19. If you would like, we invite you to use the chat to share where you're calling in from today, and a reminder to open the chat, click the chat bubble at the bottom of your WebEx. A panel will appear on the left-hand side of the WebEx. Please also use the chat if you have questions or comments throughout the program, and definitely chat to all participants so everyone can see what you're saying. If you have any technical questions, please chat directly to Sarah Kramer, the host for today's call. Excuse me, and today's program is being recorded. The program will be available on the IHI website as soon as we can get it up there, and now we're going to get started. So it is really hard to imagine right now, but when the COVID-19 pandemic subsides, healthcare delivery may never be the same in the U.S. and in many parts of the world. And maybe it feels ironic right now, that's probably a good thing. The status quo wasn't where most health systems wanted to be anyway, even as this pandemic took hold. And now daily we're seeing possibilities unfold that may well become a welcome part of patient care. Now, not the desperate scrambling for supplies to keep the healthcare workforce safe, of course. That's a constant reminder of something we probably never want to repeat. On this, the first in a series of free virtual learning hours from IHI devoted to COVID-19, we're going to dive into current realities on the ground and what we can do to help. We're also going to reflect on real-time innovations and improvements we're learning about. Virtual learning hours are one of the free benefits of IHI's new membership program. For the next 2 months during these unprecedented times, we are sharing them with the entire IHI community. So I keep saying we, so let me tell you who I mean for this next hour. IHI President Emeritus and Senior Fellow Don Berwick, and IHI President and CEO Derek Feely. Both are going to be with me and with all of you each week for the next 8 weeks, bringing their insights to bear on a variety of topics related to COVID-19. So a big welcome to you both, a huge welcome to everyone joining us. We're going to hear from Derek and Don for about 25 minutes, and then we're going to turn to your questions and comments for a Q&A. So Derek and Don, I'm going to start with Derek first. I do want to, let's start off by asking each of you, what can the quality improvement community, including IHI, contribute at this time? Thanks, Derek.
Thank you, Madge, for convening us, and thanks to everyone for joining Don and I for this first of these series of conversations that we want to have with you. We really want this to be of service to you over the next 8 weeks or so. We hope that you will drive our future agendas, and it's great to be with so many of you to kick us off. One of the things that Don and I wanted to recognize is that these are complex times. We've probably never experienced a set of circumstances quite as complex and challenging as the ones which we're facing right now. Even those of us who have been around health and healthcare for a long time, and I think most of us would agree that we've never faced anything quite like this. So what do we have to have in our minds as we tackle these kind of challenges? There's a slide with a quote that I like to use, which is just this recognition that there's no magic bullet here. There's no one right answer to a set of challenges quite as complex as the ones which we're facing, and that this is going to require some kind of mobilization of our whole system in order to help us find a path through this. And so one of the things that Don and I want to begin to explore with you over this series of conversations is, what's the role of the quality improvement community here? What can we contribute together that will help us find the solutions to this complex problem? And if here's one of the ways in which I find it helpful to think about this. If you can just go to the next picture, it will help me remember what I wanted to say to you. And that is that we tend in these situations, particularly in times of crisis, to move towards the left-hand side of this slide, to move into command and control type responses to challenges of this kind. And frankly, some of that is probably necessary. If we're in the midst of a fire, you certainly want the fire commander to exercise command and control. If I'm sitting in New York State right now, I want Governor Cuomo to be doing some of the things that he's doing. And so some level of command and control is going to be necessary here. But my growing sense is that while that's necessary, it's insufficient. And that at some point we're going to have to engage the quality improvement community, and we're going to have to mobilize social action. And our sense here is that the systems who will best serve their populations are those who are able to blend these three kind of approaches. Of course, we need some direction, and we need someone to take control of the situation, but not in a way that overpowers or stifles quality improvement interventions and the mobilizing of social action, not in a way that stifles innovation. Why is that important? Well, I think if the fact that the quality improvement community can bring, firstly, a different perspective to bear, much more likely to bring an outside-in kind of perspective, much more likely to bring shared knowledge to solve these kind of problems, rather than a top-down approach. Much more likely to bring a whole systems perspective than would be a top-down approach. I think the quality improvement community can also bring a different perspective to decision-making, much more likely to make decisions that are connected and integrated, rather than set up separate accountability systems. And there's something about what's the role of all of us as leaders over this period. Whereas in the command and control world, people are much more likely to see their job as managing people and budgets, and again, that's likely to still be pretty important, but again, unlikely to be sufficient. We need a set of leaders who are willing to act on the system. And I think looking back at crises that I've been involved in, the management of it in the past, my sense is that they tend to be overmanaged and underled. And so a real opportunity, I think, for the quality improvement community to step up and provide leadership that acts on the system. And then there's also something I think about ethos and the mindset that the quality improvement community can bring to the tackling of this complex problem. And for me, the key thing is learning. We need to replace some of the control that is exercised by learning and by coming together. And we'll explore in the course of this hour some of the things that we already see happening through generous sharing of knowledge across systems and indeed across countries. And then the last point I wanted to make, Madge, was something about a contribution that the quality improvement community can make, specifically in times of crisis, and particularly around how people tend to feel. How do we emote in these kind of crisis situations? And what we often see is people feeling a fear of failure because people's lives are at stake, a loss of heart because they get overwhelmed by the sheer deluge of the work and the magnitude of what they're facing, and that in turn leads to people's energy sources being depleted. And we know that quality improvement can replace that fear of failure with disciplined testing and learning, We know that quality improvement brings energy and heart and purpose to people. And so I think there's quite apart from a technical approach that we can bring from the quality improvement community, there's also, I think, an emotional and a social duty on us right now. So those are some of the things, Madge, that are uppermost in our minds as we're thinking about how does IHI contribute to mobilizing this quality improvement community to bring the best of what they have to offer to bear on this complex and thorny problem.
Thanks, Derek. And I'm glad for your last points. We'll talk about that a little bit more further in. The events of this year really follow on a year in which perhaps every other day we were talking about burnout in the workforce. So I think that's very relevant that this has come subsequently and what the connection might be. All right, to Don now. Don, some of your thoughts about the quality improvement frame and the community therein.
Thanks a lot, Matt. First check. Can you hear me okay?
Yeah, come a little closer.
Okay, great.
Okay, good.
Raise a finger if I need to speak louder. I absolutely endorse everything Derek just said. I'll add a few more thoughts, especially around the role of quality improvement frameworks in the communities that we represent. But I have to begin with thanks. Thanks to you, Madge, and to the team, Sarah and Vicki and Mike and the whole team that's put this together on such short notice. I'm really looking forward to these sessions with Derek. It's a chance for the two of us to reflect on what we're learning, and that's a real gift to us. And we're going to be having guests join us through the time. We'll think of you'll think that the community will think of themes, and we'll find people to join us. But this is a real gift to me, and I thank you for the chance to work with Derek on this. And thanks to the participants. At these busy times, I'm constantly amazed at the willingness of so many people to come together and take a breath and listen to each other and share. And I hope this is a sharing community. Derek and I really look forward to learning from you as you contribute your questions and your comments. So let me just reflect briefly on your question, Madge. Well, you have to start with emotion. I'm scared. I don't know what's going to happen. And every morning I wake up wondering what the news will bring, what my daughter, who's a doctor, will tell me about what's happening in her hospital. Friends of ours of IHI all over the world are calling in and telling us about, in some cases, very, very serious burdens and a lot of unknown in the future. So, at times like that in my life, when I'm feeling anxious and don't know what's going to happen, my refuge is to get together with other people. I think that there's so much more that can happen when we're together and separately, including a lot of social and emotional support, and I'm looking for that. We can get through this much better together than separately. Unfortunately, because we're forced into the virtual world, we're having to learn how to do it differently, as we are right now. Instead of being in a room together, we're on the web together, and we have to learn our way into that and to how that can yield the supports we need. The tension is real. IHI has a number of very active networks now. Our Leadership Alliance has a listserv for the 55 members of the Leadership Alliance that's on fire. I mean, it is unbelievable, the pace and the momentum of people asking questions, answering questions, sharing their feelings. We have started a process called Hive that perhaps Derek and I can talk a little bit more. With the Hive organization, IHI now has really a global learning system that we're engaging IHI people, faculty and members in, and I hope that grows a lot because this is another format for exchange. I'm on the World Health Organization's Global Patient Safety Network, which anyone on this phone can be on as well. There's a tremendous amount of global knowledge there, so we're finding ways to exchange information in this virtual world and to exchange support. When I think about what quality improvement can bring to this, your question, Madge, here's the framing I'm using. When you're anxious, when you're fearful, when there's uncertainty is around, frameworks help. It's just like getting your mind in order and saying, okay, everybody take a breath. Here's a way to think about what's happening. And one of the ways to think about what's happening for me that I've written about is professionalism is happening. We are all, as a community, trying to help our community, and we're doing it together. And the kind of communitarian spirit that Derek referred to, I find immensely important, and it is a foundation for improvement. When we're together and take a breath and help each other, we can get stuff done. So that part of the framing is, what are we here for? What's our purpose? And our purpose is to help people. That's what healthcare is about, and we're going to do that. I think in the Buddhist tradition, the term, as I remember, is sangha. It's the sense of a community being together. You're not alone. You're with others. Now, given that foundation, quality improvement, I think the theories we work with does bring, for me, a framework. For this morning, I think I'll just go back to one of the core frameworks we use, which is profound knowledge. That's the 4 categories of knowledge that W. Edwards Deming speaks about when he tries to coach us into how to organize ourselves to make something better in a very complex system. The 4 elements, I forgot to send the diagram in, I'm sorry, but it's easy to remember. Most of you know it. They're thinking in systems terms, knowledge of systems. There's knowledge of variation, which is how one uses information, especially quantitative information. There's knowledge of psychology, which is how we are together. And then there's knowledge about how to grow knowledge. Plan, do, study, act, cycle. Now, that's not a panacea. Doesn't solve the world, but it is a way to organize thinking, and that's the way we can use quality improvement to look at what's happening. Systems thinking, absolutely. The whole world, every nation, every community, every organization has now got to respond at a level of interdependency and interaction that we never, ever thought of before. We would never have pushed this hard, but it is about systems and systems design. One of the examples that maybe we'll dive into in this series is supply chain management. How do we move equipment, supplies, knowledge, people around in a way that's most responsive to the local need? That's a highly difficult and important way to think in systems terms. Also, systems terms force us into thinking about interrelationships and interdependencies in ways we never have before. We really now depend on each other at a level we've never had before, and understanding what that sort of diagram looks like of how we're depending on each other and what the system is. Derek and I have the great privilege of working with Michael Dowling, who's the CEO of Northwell Health in the New York area. We were at Northwell all together before the COVID hit, and it's an amazing organization, 23 hospitals. And I'm talking to Michael just about every day just to check in, but also understanding how that immense 23 hospital system is thinking about itself, about how to move things around and how to respond, how to get ready. Hopefully we'll have Michael or his colleagues on at one of these sessions, and we'll talk about how you deal with surge. That's systems thinking. Then there's knowledge of variation. That's use of data. This country fell way, way behind because we weren't equipped to do the diagnostic testing that we would have needed to do to be able to get ahead of this curve with knowledge about where is the virus appearing, who's getting it, what are the patterns of acquisition, and we're still behind, but we'll catch up. But even given that, the use of data and information and understanding variation is absolutely crucial in this environment. And everyone on this webinar is probably seeing, as I am every day, those curves come, the modelers, people trying to figure out what is the trajectory here. This has to do with interpreting numbers and variation. It's a profoundly important topic here and one we should get into this series. So we need to become smarter and smarter in how we're using and consuming information and sorting wheat from chaff so we know what bad data look like. The third is psychology, which probably is the most important. It's what Derek referred to right in his opening remarks, how we are together, how we depend on each other, how we support each other, how we negotiate with each other. That all matters now at a level beyond anything we've experienced before. And for Deming, that pot, psychology, is a big, it includes cognitive psychology and social psychology and group psychology and learning theory, but it also includes understanding motivation. And I'll tell you, as I'm watching this outpouring of generosity and help beyond anything I've ever seen, to me, it restores some sense of human spirit, even when our leaders are not acting the way we wish they would in the United States. Not all of them. We're seeing the workforce, us, the people, coming together with the generosity and professionalism that I've never seen before. I wrote about this in an op-ed in the New York Times on Monday, beginning with a story of my daughter, who's a doctor, going to work every day now. So this respect for the workforce and understanding what people need to be nurtured, that's really crucial. And I think I'm seeing a lot of organizations tune in on that. IHI has launched a breakthrough series, a large collaborative called Joy in Work, and I didn't think anybody would show up yesterday for the first meeting, which had to be virtual. Not only do they show up completely engaged about how to restore and maintain spirit and motivation and joy, even under crisis circumstances. And the last part of profound knowledge is the learning process. Plan, do, study, act. That's what Derek was referring to before about the learning. That's tests of change. We're going to have to be really better at that than we've ever been before because we don't know what to do. We don't know what the future holds. So our ability as a community to try things and report to each other on what we're learning, not sloppy science, but discipline, local tests. Northwell, the organization that I just mentioned, is trying to figure out how you can put more than one person on a single ventilator. If they find out that, and 5 other places do, you all need to understand that. That'll increase ventilator capacity. In the Joy and Work conference yesterday, we looked at a wonderful asset that's come out of Soffit Royal Infirmary in England, near Manchester. And Soffit Royal has a checklist as you leave the building. It's a personal checklist as to how am I doing. And it's a wonderful asset. And I could hear right on that webinar people picking that up and saying, I'm going to try that tomorrow in my local organization. So that's not a panacea, but think in systems terms. Let's get better at using data. Let's understand each other better and work like we've never had been before, hand in hand. And let's try things. And maybe that's even a framework for some of the seminars we're going to have. So back to you, Madge. Thanks for the chance to opine on that.
Thank you both. So Derek, we're going to raise a lot, well, let me back up before I say Derek. We're going to raise a lot of issues kind of intentionally on today's program. We promise you we're going to get into more depth on all of them over the course of the 8 weeks, and we're going to try and be very agile and fluid. I think we wanted to at least touch upon some things and some framing for this program. And if there's any information or terms or names you're hearing about that you're not familiar with, please chat that in. We do have a lot of links prepared that Vicki prepared, but we want to make sure that you're not lost at any point. Derek, Don just mentioned something coming out of England, the UK. Maybe just, I had allotted a little more time for this today, but maybe we can just shorten it so we can get to some other issues that are going on with the workforce right now, which I think is very uppermost in people's minds. Briefly, what are you hearing from some of our partners in other countries? How they're managing, how they're learning. Of course, mainstream news, understandably, goes right to the crisis points, and I think we need to know about that too. But what about what's being learned along the way? Thanks.
Yeah, thanks, Madge. And one of the vantage points we get at IHI is that view across many countries and communities. And so the trajectory in each of these countries that we're working in is somewhat different. People are at varying stages along some kind of growth trajectory in terms of the numbers of people who are affected by this. And so people's experience from that point of view is somewhat different depending where they are on that curve. But in terms of the healthcare system pressures, there are at least 3 things that I see every single system that we interact with having to deal with. The first has already come up in the chat several times. It's the dire and deeply concerning shortage of personal protective equipment. I heard a nurse yesterday describe this in a way that really drove it home to me. And her language was, this is akin to asking a fireman to fight a fire wearing a bathing suit. So that's international. There's a shortage of PPE and other equipment, and something needs to be done to mobilize people's energies to solve that problem quickly. And then I think that's a contributory factor, but not the only factor in what we're seeing across all systems, which is extreme levels of stress and burnout. And so in that slide that we showed briefly earlier with the various pictures, that's just a reflection of people's experience just now of working in the healthcare system. They're tired, they're stressed, they're bloodied, and they're heroic. And we see that across the world. Healthcare workers go in the extra mile, doing remarkable things. And then the third thing that we see, Madge, across the world is people getting ready for the surge. Preparing the ground, thinking deeply about how are we going to meet these kind of needs? What are we going to do if we can't get the PPE that we need? What innovations can we make? And we can talk about in a few minutes about what some of those examples are. And this is also, and this is my last point, Madge, and I know you want to keep this short. This is also where we at IHI are trying to do our bit. And so Dawn mentioned this COVID-19 global network that we're in the midst of really establishing. We've been testing the robustness and the utility of that over the last week with our fellows and with some of our closest partners. It's proving to be an incredibly helpful learning platform for them. It's a way of people exchanging information on a real-time basis about how to solve a particular challenge. And so we're ready now to kind of move that to full global utility. And again, our intent there is to be a platform where people can share knowledge across systems and across countries.
Thanks, Derek. So I think maybe we can combine this next little area, and then we'll start getting ready to answer questions and see what's on the minds of people who've joined us. So the first thing I wanted to ask both of you, should the American people, should people in other countries be surprised about what we're witnessing in terms of critical care supplies? Maybe if you really are deeply embedded in healthcare, not a surprise at all. And then, of course, we have the flip side of everything we've been witnessing to solve those problems, particularly protective things for staff working with patients with COVID-19 or who may have that. So, Don, let's start with you. You've been at this for quite a while. Should we be surprised?
It's a tough question, actually, Madge. It's Monday morning quarterbacking, the American phrase. Looking backward in time, so you're always smarter than you were at the beginning. So we could say, well, gee, how could we possibly not be prepared? But to be kind to ourselves, nobody knew something of this magnitude would hit so fast, so hard at this point. So it's easy to say we should have, but we didn't. That said, I must say there is a bigger question here. I got to co-chair a National Academy of Medicine expert workshop process last year before anyone heard of COVID, before I heard of COVID. A one-year process supported by the Assistant Secretary for Preparedness and Response in HHS in the United States. And the issue was, are we prepared, and is the private sector prepared for so-called 21st century threats? 21st century threats include biologic outbreaks like this one, bioterrorism, large-scale trauma from a massive explosion. They include what would happen if the grid went down due to cyber terrorism. So we lost all our electricity for weeks. And this was a pretty serious inquiry by dozens, if not hundreds, of experts around the United States that are looking at our level of preparedness. And frankly, the conclusion was we are not prepared. We haven't invested where we need to. We have prototype regional structures. There's a wonderful one actually headquartered at Mass General in Boston. There's one in Nebraska. Bellevue Hospital, New York, has done work. All this under sponsorship by the government to set up prototypes, but we have not spread those prototypes. Habits of cooperation are not in place. Supply chain management is not in place. And the findings of that process were pretty serious. Unfortunately, what has happened is sort of what we imagined. So in retrospect, we should have invested more on the infrastructures that we're facing now. And after this horrible period is over, we'll hopefully take this lesson learned and make sure that the next threat, should one arise, we're much better prepared for.
At the same time, thank you, Don. Derek, you are among those also in all kinds of conversations, along with Don and others, seeing all this amazing real-time innovations. As I said to IHI's Dr. Kedar Mete earlier this week, we used to think of workarounds as kind of a bad word, indicative of system failure. And of course, the workarounds now that we're witnessing are, positively life-saving. Some thoughts on that?
Yeah. So I think my first thought, Madge, is we need to speed up. We need to accelerate our innovation processes. So at IHI, we're taking that very seriously. For example, we have a pre-existing set of innovation approaches which largely run in 90-day cycles. And at the moment, we need closer to 90-minute innovations than we need 90-day innovations. And so we're trying to find ways to really speed up our innovation cycle without losing the rigor and the value of the innovative solution. We also are seeing all around us folks innovating in real time. So I've begun this week talking to some of our colleagues in the Providence Health System in Seattle, Washington, about a program they started, which they call the 100 Million Masks Challenge. And so they're trying to find a way to create and to source 100 million protective masks. Some of those for community use, so that people can use them in the community and free up masks to use in the hospital system. Some of them to retool existing facilities to manufacture masks. Some of it is about how do we reprocess our masks. And so they have asked IHI to help them to scale up that effort and in a way that we hope might have a broader applicability. I also see people innovating around new ways to connect. And I think that's a really important point. There's been some conversations in the chat around behavior change. And one of the ways in which we're having to change our behavior is we're having to be distant from each other. That's why one of the reasons why Dawn and I have taken now to talking about physical distancing rather than social distancing. At a time like this, we need ways to socially connect, even while we're physically distant. And it's great to see some of the ways in which people are innovating around those kind of things. New ways to stay in touch with each other, new ways to progress our work. At IHI, that means new ways to teach. So we're doing much more of this kind of thing and trying to gather many people virtually while we can't gather them face to face. And the third and final thing, Madge, I just want to take this opportunity to draw people's attention to and to advocate for is, I think one of the innovations we need is how do we celebrate our workforce at this time. And so I was really heartened yesterday to see the round of applause that went around the United Kingdom for the healthcare workers, and to see how many people participated in celebrating the contributions of our healthcare workers. And we need to do more of that and find new and innovative ways to celebrate the people who are keeping us safe right now.
Don, do you want to add to that sort of the innovation theme, and then I think we'll transition to some of the questions and comments. And we also can already applaud everyone's wonderful use of the chat transcript in terms of talking to one another and offering ideas. You can download the chat transcript as you get off the program today, and it will also be posted to our website. Don, thoughts?
Yeah, thanks. I'm amazed by this chat. It's a good example of the exchanges Derek was talking about. And let me again second Derek's comment on the way we thank our workforce. By the way,
come a little closer, Don. Just come a little. Thank you.
One other thought, by the way, it's about psychology and who we are. But now, when I go now rarely, but I go to the grocery store to stock up, I look at those clerks who are standing there, exposing themselves to risk, gas stations, essential services that are staying open, not just medical. And each one of those people is a kind of hero in a way. I'm sure they don't think of themselves that way, but these are people who are not running away from their posts. They're staying there for income and for commitment. And it's inspiring. I mean, it's all about innovation now. I love what Derek said about the pace of PDSA cycles. This is minute-by-minute learning right now. And one of the things that I think we need to learn more about, and Derek and I perhaps will talk about this as we go further, is how these learning exchange processes work. I mentioned the volume of exchange in the Leadership Alliance, listserv. You can even look at this chat right here. How do we curate and harvest from this so it isn't this overwhelming flood? The idea here is for you on this call to find a way to pick up an idea and put it to work quickly and then report back on how it worked. That's the community we need. And we at IHI and others, the World Health Organization, the CDC, OECD, the World Economic Forum, they're all maintaining curated exchanges to say, hey, everybody, look at this idea. But it's not easy to do that. But we have to make changes. We're going to have to adapt and change. One topic that arises there, Madge, if I can just take one more second, that I've become kind of obsessed with, and I'm no expert, I'm new to it, are what are called crisis standards of care. I think that's a term of art in the world of preparedness. What it means is that when so much demand is hitting us, the surge comes, or we have these very unusual demands like for personal protection, the old rules may not work well at all. In fact, they could be quite the opposite. They could be handcuffs on us. A very simple example that we've overcome already is in the United States, licensure of physicians is state licensure, but telemedicine is cross-state. So if we apply the state licensure requirements to the telemedicine world, we have tied our hands. We can't offer expertise at the pace we want. What is that list of new ways to think about our rule base? And it even goes uncomfortably to ethics. You know, what challenges in our ethical decision-making are we going to have to make? I shudder about those, but we have to be honest and feel and think about what the rules are. For leaders on the line, this is about you. This means what can you flex in the rule base you work from that allows your workforce to be much more agile in learning and meeting needs without irresponsibility. And I think that's a topic we should dig into at some point.
Thanks, Don, and lots of good stuff coming in the chat. Derek, pick up on this theme about leaders and something you've written about, have been very engaged in, your leadership notwithstanding as an example. But what are you hearing from leaders right now in terms of what they're looking for and what might be even some good models? Thanks.
I had a chance yesterday, Madge, to talk to an assembled group of leaders who are working on age-friendly health systems. We had about 150 folks on the call. These are a set of leaders who are trying to lead their systems to provide the very best care for older people that they can. And we talked about how do we respond as leaders in these challenging times where the demand for leaders' attention has magnified, hugely. Where do we focus as leaders? And as Dawn says, at these times, frameworks are particularly useful. And so I have had a framework that I've tried to stick by in good times and in tough times. But I think, and those folks at IHI who know me know I always think in threes. So there's just three things in this that I try and adopt, and maybe some of it will be useful for the folks on the call. And they all start with T, which helps me to remember them. And so the first is transparency. This is a time where folks need transparency from the leaders. It's what Jim Collins in Good to Great calls facing the brutal facts with confidence. And so people really need us. We shouldn't sugarcoat. We shouldn't pretend. We should be transparent. Back to some of what Dawn said earlier about how do we use the data and present the data in transparent and compelling ways for people. The second T is team. I see leaders retreat into kind of solitary thinking at this time. I see them overwhelmed by the daily pressures and forgetting to connect with their peers and their colleagues. And every single leader who is dealing with this just now needs a support system. And so we need to do this together at this difficult time. And the third is a little bit of a stretch with the T's, but I call it trusted calm. People need their leaders to be calm and assured and measured at this time, and they need to be able to trust that it will be so. I've seen so many leaders undermine a lot of work to provide transparency, to do it in a team-based way, and to generate calm, and then one moment of panic or anger or frustration undermines all of that. And so those of you on the call who are in leadership positions, if you're looking for some kind of framework to refer to, that's mine. It's an N of one. So you'll just need to take it in that spirit. But I've always found it helpful in these times in particular to be transparent, to find some kind of support system to do this as part of a team, and then to be the voice of trusted calm as best as you possibly can.
Thank you, Derek. Dawn, there are a number of questions. I think people are also trying to do what we're doing, which is sort of 30,000 feet, 20,000, 5,000, and then right into it. Some of the things that are being talked about in the chat having to do with staffing models, again, sort of looking at what are options around personal protective equipment, ventilators, et cetera. In Massachusetts, in the last 24, 48 hours, we announced we're going to accelerate graduation of medical students in their fourth year and grant them, those qualified, 90-day licenses to get more engaged. Students themselves very much eager to do this. That's certainly innovative and important. And there are a number of things going on in the chat about right at the bedside sort of models of care and how we're going to get at some of that nitty-gritty stuff that often sort of happens in great stress moments.
If I understand your question, Madge, it goes back to the curation point that I was trying to make.
Yeah, come forward a little more. Yeah.
Yeah, we have this embarrassment of riches, which is lots and lots of ideas now, at least in the social networks we're running. And I wonder, too, about how we're going to harvest from all of this local bedside innovation lessons that really can share and spread. And there has to be this balance between anything goes and some sense of responsibility and discipline in drawing inferences from what's going on. But we have to do that at a pace and level never before experienced. One of our colleagues at IHI, a close friend and an invaluable expert, is Don Goldman, who is both an infectious disease and epidemiology scholar and a scholar in improvement. And I use Don as kind of a vetting force. Take 3 or 4 ideas that have come before us and then run it by somebody that really knows the subject matter. I think we need to formalize some kinds of review like that without chilling the energies of innovation that are going on locally. I'll take that one case that's very interesting to me, which is this multiple patients on a single ventilator. That came up originally for me in an email chat. I don't know if it's a good idea or not, but I think we can know very fast. I think there'll be places trying to work with that and figure it out, and exactly how we can trace that vetting process and be able to say, okay, here's what we now know about that innovation. Repurposing and cleaning N95 masks. Some of the chats are actually about innovations in reuse of N95s. I don't know that field, but we need to harvest what people are trying and then run it through some kind of curation process. I know that's a more complicated answer than you were after, but that's what I think. Madge, let me comment also back to the leadership point. There are a couple of chats that are coming in. Neil Baker, Pascal Vaux, and others are asking a very edgy question that I guess we need to tackle, which is the voice of this improvement community in the political scene. Our political leaders some are doing magnificent stuff. Others are really letting us down. And, Pascal and Neil are asking, should we be a voice for holding the political world accountable? I say yes. I think there are certain things we all need to be takes shared responsibility for, and one is to insist that our political leaders honor science, that they honor the need for investment in meeting this need. They can't engage in wishful thinking. We need to be disciplined about use of the data we're getting, and I think we do have a role saying we need to work together well, and the political leaders who aren't helping us with that need to be held accountable.
Okay, thank you, Don. Well, in our remaining minutes, I think I want to maybe just highlight a few things in the chat, and I again want to promise that we're going to revisit a lot of these and again appreciate all the back and forth that's going on. And Don Goldman, we see, is, of course, in the chat. Thanks, Don Goldman, for your wisdom about infectious disease and other things. Let me just, maybe I'll go to you, Derek. You mentioned age-friendly health systems, and one of our flagship initiatives here at IHI with partners, including the John A. Hartford Foundation. Somebody put in a comment in the chat, which I can appreciate, and I'm sure others can too. Do I have a DNR on my back without my possibly knowing it? And I think these issues, alluded to by Don, that's one point of intensity there. And then, of course, the degree to which many of the things we're striving for anyone hospitalized who is a lot older, mobility, being able to, in some ways, reach your potential as opposed to being confined. Really, any thoughts that you might have? One, of course, is a very difficult subject. By the way, I do want to say we do have resources in our newsletter coming out on Monday, and maybe some have seen them. From the Center to Advance Palliative Care has a lot of really terrific thinking. Our own conversation project, kind of within IHI, is working very, very hard to make connections around people who are most vulnerable right now. I see Maureen Bizignano, formerly our former president and CEO as well, and Emerita, talking about that too. So I think there's much more to come. But Derek, some thoughts about kind of this aging issue and coming to terms with some of this as we move forward.
Yeah. So, Madge, I'm struck by the level of interest in that, and it may be something that we want to focus on in a future program. Don and I also had some outreach yesterday from people who are active in and around the nursing home and care home sector, where there are a number of very vulnerable people who need enhanced levels of care just now. One of the innovations that IHI is currently working on is how do we take safe care of people at home, because increasingly folks are going to try and deliver care at home to patients, and we want them to be able to do that safely. Incidentally, we're also doing the same with telemedicine. Despite the fact that telemedicine is reasonably well established, and it's going to grow rapidly over the next few months and beyond, actually very little is known about the safety of telemedicine. And if we're going to do that, we feel IHI has a role in figuring out how to provide telemedicine to older people and others in the safest possible way. People are saying they're having a hard time with that audio, so I'll just come a bit closer. What we're trying to do in our age-friendly health system work, and indeed in pretty much every project that IHI is doing, is pause and pivot wherever we need to. So part of the conversation we were having with the 100 or so teams on our age-friendly call yesterday was, what do we need to do to reflect the current reality? Our interventions in that work, we call them the 4 M's, but they start, as so much of our work does, with asking that important question that Maureen and others have promoted about, and Susan Edgman-Levitan helped us to understand the power of, around what matters to you. And so it seems ever more important to start our conversations with patients and family members with that question, not just asking what's the matter, but asking what matters to them. And then we need to have a set of resources to back that up. That's where I think the materials from the Conversation Project can be incredibly helpful to people, and they are freely and readily available on the IHI website. It's where the work that Maureen referred to in the chat that she's doing in Massachusetts with Atul Gawande is going to be really helpful to us. We need some resources to back up the answer to that question and help us to respond effectively to it.
Don, you're going to get probably the last little word here. What would you say at this point, I guess kind of as we move forward, might be some of the ways we can think in terms of priorities right now? Or do we have to think in terms, we often talk about priorities, so we have several at the moment. Any reflections on that?
I would, taking your point in a smaller frame you're asking, for this 8-part series, I hope that Derek and I and you imagine the team can focus in on what the priorities are for the people who are participating in the chat. And so this is a really good time for you to be telling us what you want to hear about and learn about, because this is a dynamic system, and we can really move toward the needs that you have. So tell us what you want to learn about. I have a couple personal things that I'd like to put on the table. One is I'm noticing how unexpectedly international the chat is. We have people from many, many countries. And I think one special sauce we can add as IHI is to globalize the thinking here. And I welcome that. And I hope we'll think about what's happening right across the world, not just in the United States. So that's going to be really exciting. I think that the other personal takeaway is, what Derek said, you put your own masks on first in the airplane, that's what they tell you to do. We really need to do that. So these particular issues are protecting the healthcare workforce so we have the energy to do the work that needs to be done. That's absolutely central. If we don't have that, the game is lost. And then that involves also self-care, which is how do we maintain energy and our own spirit, we need to focus in on that. But I'll tell you, the topic list is a lot bigger than 8, so we're going to have a lot of work to do in the sessions.
I hope you don't have anything else to do.
I'm 100% on this. Several of you have asked about the Salford Royal Infirmary checklist, which that's near Birmingham, not Manchester. I think I put it in the wrong part of England. But
you were right. You were right first time, Don. It's near Manchester.
Near Manchester. Okay, so I've got to go back and visit. I forget. We need to get that checklist out to you. It's a very good example of putting your own.
It's on the next slide. If Sarah just clicks to it.
Next slide.
Next slide.
Next one.
Next one. Let's see what that.
There it is. Right there.
Oh.
Everybody take that and put it to work. That's the kind of stuff I'm talking about.
Okay.
About adding energy and spirit to the people that have to have it. So, Madge, thanks a lot for the chance to do this. I'm looking forward to more. Let's keep that checklist slide up for a little while so people can copy it down.
Okay. Derek, is there something? Derek, whoops. I'm sorry, my own screen went fluey. Okay, back. Derek, parting words from you.
Back to where I started. Thank you to everybody who's joining us. We hoped that we would get some kind of conversation established from this. Don and I's wish was that there shouldn't be E&I talking, but rather a facilitated conversation. And the thing that's really impressed me and pleased me so much with this is just the richness of the chat, people's generosity and being willing to share their ideas, the learning that has been generated just through this one conversation for 1 hour. I'm truly grateful for that. I'm grateful for the spirit in which people have shown up to this first conversation. And I'm already looking forward to seeing many of you next Friday for version 2, where, as we indicated, our plan currently is to think about getting ready for the surge. That's the way in which we're currently thinking, and we're gonna try and get some of our colleagues from North Wales to join us.
Okay, thank you, Derek. And we have reached the end of our time together today. As we wrap up, please take the poll that is open on the right-hand side of your screen. We really do need your feedback, as Derek and Don have both been saying. Also, if we didn't get to your specific question today, do stay connected with us at IHI as we work on making more of what we're starting to learn available. And a reminder, your concerns may well be addressed in some of the shows coming up after this. And as you all have just seen in spades again, you have a lot of rich experience underway right now that you can share with one another. So a huge thank you to our amazing audience, also to Don Berwick and Derek Feely. And thank you, everyone, for taking the time to participate in today's program. Be on the lookout for the archived edition that will be posted to IHI.org as soon as we can humanly get it up there. We will be back next Friday at 10 a.m. Eastern Time, focusing, we hope, on how to prepare for a surge of patients in hospitals, gaining some experience from what Northwell is doing. So details soon on IHI.org, and there are other resources on IHI.org about COVID-19 as well. So on behalf of everyone, Don and Derek, of course, and our crew putting this together today, everyone at IHI, we wish you health and all the best. Stay in touch. For the Institute for Healthcare Improvement, I'm Madge Kaplan. See you again soon.